The brain is running out of room inside the skull, and the body's absolute last warning sign is a deadly triad.
Welcome to this explainer. If you're a nursing student gearing up for your Med-Surg exams or the NCLEX, you are in exactly the right place. Today, we're tackling a high-stakes, absolute must-know topic, Increased Intracranial Pressure, or ICP. We're going to break down exactly what happens when the brain quite literally runs out of room, how to spot the absolute earliest warning signs, and those heroic nursing interventions that can pull a patient back from the brink. So let's get focused and master this together. Section 1. The sealed box. To really understand increased ICP, we have to start with the environment. Okay, let's dive into this. Imagine the skull not just as bone, but as an inflexible, completely sealed vault. It's a highly claustrophobic space with absolutely no room for expansion, and the Monro-Kellie doctrine holds the key to this entire disease process. Inside that sealed, rigid skull, there are exactly three things: brain tissue, blood, and cerebrospinal fluid, or CSF. Because the total volume of the skull is completely fixed, if any one of those three elements expands, say, from a swollen brain, a bleeding hematoma, or trapped CSF, one of the other two absolutely must shrink to make room. But here's the catch. Those compensatory buffers are incredibly small. Once they're exhausted, the pressure inside that vault immediately and violently spikes.
And when that pressure spikes, it triggers a terrifying, lethal timeline. First, the volume rises. Next, that brief compensation fails because, there's simply no more room. Then, cerebral perfusion drops. As intracranial pressure climbs, it actively fights against the blood trying to enter the brain, dropping what we call the cerebral perfusion pressure, or CPP. This lack of blood flow causes ischemia. The ischemic brain tissue then swells up, creating this vicious cycle of more edema and even higher pressure. If this cycle isn't stopped dead in its tracks, it leads to step 4, fatal herniation. The brain is literally crushed and pushed down through the base of the skull, compressing the brainstem and resulting in death.
Section 2. Early signs. Act now. Obviously, we do not want our patients reaching that final stage. As a nurse, you have a critical but very subtle window of opportunity to halt this vicious cycle. Recognizing the early signs is literally what saves lives. Look at the stark contrast here between these phases. A decreased level of consciousness, or LOC, is the absolute earliest, most sensitive indicator of rising ICP. This might just look like a patient being slightly more restless, irritable, or maybe a bit confused. Contrast that with the late signs, like Cushing's Triad, which are blaring, ominous alarms that the brain is already failing. You simply cannot wait for the late signs. All right, let's put this to the test. Listen closely to this high-stakes NCLEX challenge. Which is the earliest and most sensitive indicator of increasing intracranial pressure? Is it A, fixed dilated pupils, B, a change in level of consciousness, C, Cushing's Triad, or D, decerebrate posturing? Drop your answer in the comments. 3, 2, 1. So, the crucial point is, the answer is B. A decreasing level of consciousness is the earliest, most sensitive sign. The other options, fixed dilated pupils, Cushing's Triad, and posturing, those only appear much later as the pressure dangerously worsens. Catching that subtle shift in alertness is your absolute #1 priority. Section 3. Late signs. Cushing's Triad. But what exactly happens if that pressure isn't caught early? As the patient's condition deteriorates into the late catastrophic phase, the signs become terrifying. We're now looking at impending brain herniation. This brings us to Cushing's Triad. You guys, this is a late, life-threatening emergency. It's the clinical picture of a brainstem being crushed. It consists of 3 flipped vital signs. First, severe hypertension with a widening pulse pressure, meaning the top systolic number goes way up while the bottom diastolic number stays low. Second, severe bradycardia. The heart rate drastically drops. And third, irregular respirations. If you see these 3 things together, herniation is imminent. Let's lock this in with another NCLEX challenge. A nurse observes a client with a head injury develop a blood pressure of 178/60, a heart rate of 48, and irregular breathing. The nurse recognizes this as A, an expected finding, B, Cushing's Triad indicating dangerously high ICP, C, septic shock, or D, a normal compensatory response. Get your answers ready. 3, 2, 1. And the answer is B.
That wide blood pressure of 178/60, combined with a heart rate of 48 and irregular breathing, is the exact textbook definition of Cushing's triad. These flipped vitals are a blaring red alert alarm of a life-threatening emergency.
Another ominous late sign we have to watch for is abnormal motor posturing. Notice the difference here between decorticate posturing, where the arms are flexed inward toward the core, versus decerebrate posturing, where the arms are stiffly extended outward. Now, while both mean severe brain injury, decerebrate extension indicates that the damage has actually reached the brainstem. It's a sign of severe, catastrophic deterioration.
Section 4. Priority nursing interventions. Okay, the alarms are sounding. The pressure is rising. It's time to pivot to the heroic rapid-fire actions you must take to battle this rising pressure and save the brain. First up, protect the airway and ensure oxygenation. This is absolutely crucial because high levels of CO2 cause cerebral blood vessels to dilate, which just spikes ICP even further. Second, keep the head of bed elevated to exactly 30 degrees and keep the neck and head perfectly midline. And this brilliantly illustrates a core concept. Gravity is your best friend here. Keeping the head elevated and straight promotes venous drainage out of the skull. Finally, if there's a ventriculostomy in place, it'll be used to monitor pressure and physically drain off that excess CSF. Next, we use medications to shrink the swelling. This is osmotic therapy. Drugs like mannitol, an osmotic diuretic, or 3% hypertonic saline act like a powerful chemical sponge in the bloodstream. Because they're highly concentrated, they rapidly pull excess fluid right out of the swollen, waterlogged brain tissue and into the blood vessels to be excreted, dramatically lowering the intracranial pressure.
Section 5. Avoiding deadly spikes. But as a nurse, it's not just about what you do. It is equally about what you absolutely must avoid. Let's shift our focus to the strict contraindications, because doing the wrong thing here can accidentally kill the patient. Everyday, routine nursing actions become suddenly lethal in an ICP scenario. Do not cluster care. I know, in most patients, doing all your assessments and turns at once is super efficient, but in an ICP patient, it causes dangerous spikes in pressure. You must space out interventions and maintain a quiet, very low stimulation environment. Furthermore, do not allow the patient to cough or strain. Do not suction them excessively, and definitely do not flex their neck or hips. Any of these actions can impede venous drainage or spike that internal pressure.
And here is a massive, urgent warning, a classic NCLEX trap you cannot fall for. Never perform a lumbar puncture on a patient with suspected high intracranial pressure. Think about it. If you puncture the lower spine and release CSF pressure from the low, the high pressure inside the skull will violently push the brain downward toward that sudden low pressure zone. This causes instant, fatal brain herniation. Just remember, no LPs for high ICPs.
Section 6. Ultimate NCLEX mastery. We've covered a whole lot of ground today, from the claustrophobic anatomy of the skull to the life-saving interventions. Let's bring these narrative threads together for a final high-impact review. I want you to anchor this critical clinical number in your mind right now. Normal intracranial pressure is between 5 to 15 millimeters of mercury, but a sustained pressure greater than 20 millimeters of mercury is a true emergency that demands aggressive, immediate treatment before the brain begins to herniate.
Burn this sequence right into your brain. LOC first, Cushing's late. A change in the level of consciousness is your earliest red flag. Cushing's triad, the wide blood pressure, low heart rate, and irregular breathing, means you are almost out of time.
You now have the exact tools to recognize and act on increased intracranial pressure before it's too late. If this made it click, subscribe. One killer Med-Surg topic every day until you pass the NCLEX. Keep studying hard, trust your knowledge, and ask yourself, if the brain's pressure limits are this extraordinarily sensitive, what other subtle neurological emergencies are hiding in plain sight on your unit? See you in the next one.